All right, good afternoon, everyone, and thanks for joining us after this break. My name is Tariq Al-Sayed, and I'm one of the cardiac imagers here in Pittsburgh, and we will talk about a complex cone operation. I will interview our esteemed panelists here, Dr. Jackie Kreutzer, Dr. Grace Van Leeuwen, Dr. Gaurav Arora, Dr. Luciana De Silva, and Dr. Adam Christopher. All right, without any further ado, we will start talking about this case. So this is a 4-year-old who was born at full term, was referred from Poland for severe Epstein's anomaly of the tricuspid valve and atrial septal defect. She was adopted at the age of 3 years, and she was thought to be high risk for biventricular repair in Poland, and that's why she was referred to our center. The mom noted that over the last 2 months, she's becoming increasingly tired with shortness of breath and cyanosis during activity. The patient was on multiple medications. She was on digoxin, spironolactone, and warfarin that was started for polycythemia. Her saturation was 80% at rest. When you look at her, she looked moderately cyanotic. She had a normal S1 and widely split S2, and she also had a 3 out of 6 systolic regurgitant murmur, best heard over the left lower sternal border. This is her EKG here, showing right atrial enlargement and intraventricular conduction delay without clear signs for Wolff-Parkinson-White on that EKG. And this is her chest X-ray, and you can see that her heart was very big, especially you can see that there is the right border of the heart that seems to be enlarged here with suggestive of severe right atrial enlargement. And then here's the checklist for pre-op echo that we perform in patients with Epstein's anomaly. And I would invite Dr. Adam Christopher from our imaging team to comment about the checklist.
Yeah, thanks, Tariq. I'll actually briefly summarize this because I think we've beautifully discussed this already this morning. Both Dr. Silverman and then Dr. Lanford touched on many of the elements of this checklist. But, you know, of course, by echocardiogram first, we do a kind of a complete evaluation of the leaflet anatomy from multiple views that I think you'll show us shortly. Of course, assessing the degree of displacement of the septal and posterior leaflets, any degree of tethering, and again, we heard this morning about kind of that spectrum of linear versus hyphenated attachments. The degree of rotation as well, Dr. Silverman touched on, but we evaluate closely by echocardiogram as well as MRI. And then, of course, paying close attention to both the right and left ventricular size and function is important in that preoperative planning stage. And I'll stop there, but I think we can discuss further.
All right, wonderful. Thank you so much, Dr. Christopher. So we will start looking at her imaging here. So this is a subcostal coronal image focusing on the atrial septum, and this is the level of the atrial septum here. And you notice that the direction of the flow is blue, so it's from the right atrium to the left atrium. Next, this is a subcostal coronal sweep. And Dr. De Silva liked this picture a lot. So you can see here, this is the level of the AV groove. And then the inferior leaflet hinge point is usually here. But in this case, because of the severe Epstein, the hinge point is severely displaced towards the apex. And also you see that the valve has extreme rotation towards the right ventricular outflow tract. You also see that the atrial right ventricle is severely thin and also dysfunctional. And the function of the functional right ventricle was thought to be mild to moderately depressed. Next, we'll look at the apical fourth chamber. So we're starting with one slice here. So you notice the severely enlarged right atrium here. You see the atrialized right ventricle, which is also severely enlarged. And then you notice also that the left ventricle has mildly to moderately depressed function, as Dr. Silverman mentioned, which is a common finding in Epstein. And also you notice the several tethering attachments of that leaflet here. And then this is the septal leaflet, and you see that it failed to delaminate from the septum, as you can see here. And also it's severely dysplastic, as we will see in other views as well. Now, in the fourth chamber, you can see the anterior and the inferior leaflet, depending on the direction where you sweep. So here we're sweeping towards the coronary sinus, and you're seeing the septal leaflet here, and then you see the inferior leaflet here, which is also severely displaced towards the apex. And then here, this is a long sweep, so showing the first orifice of that valve towards the apex, and you see that there is failure of the septal and inferior leaflet to coapt. So this is the first orifice of that valve. And then as we get towards the right ventricular outflow tract, we also notice the valve to be shown on FOSS here. So that was suggestive of a double orifice tricuspid valve. When we put color over that tricuspid valve, there was severe regurgitation, as you can see here. And then as we keep sweeping, we notice that second orifice, which is towards the right ventricular outflow tract. Next, we're looking from a parasternal long axis view here, and this is also a sweep, and it can show beautifully the tricuspid valve on FOSS. Then as we sweep anteriorly now here, we're seeing the pulmonary valve. And then as we sweep more posterior, we see the atrialized right ventricle here, which is thin-walled and dysfunctional, and we see the abnormal tethering attachments of the anterior leaflet as well. Next, we'll look at the pulmonary valve in this patient. And you can see that the annulus of that pulmonary valve measured mildly hypoplastic, but there was good antegrade flow by color Doppler and by spectral Doppler. Next, this is a parasternal short axis view. Again, you see the rotated tricuspid valve towards the right ventricular outflow tract. We see this is the functional right ventricle, which we thought the function of that was mildly to moderately depressed. And we also see that the left ventricle here is compressed by this severely dilated right ventricle, and the free wall has depressed function. So we thought that there was a mildly to moderately depressed left ventricular function on this echo. And this is with color, again, showing the severe degree of tricuspid regurgitation. And next, we will talk about preoperative cardiac catheterization, and Dr. Jackie Kreutzer will join me here to discuss that.
Thanks, Tarek. So one of the questions is, when do we do a preoperative cath? We don't always do a preoperative cath in these patients, but one of the indications that for us is important is if a patient is cyanotic, so then we want to estimate the flow and especially check the PVR in case at the time of surgery we need to do a Glenn. So that's one of the criteria that we use. So cyanotic patients typically do get a preoperative cardiac catheterization to assess hemodynamics, and we also assess coronaries as well. So if we go forward, oops. Is the cath diagram here? Yeah, okay, sorry, thank you. So in this is the cath data on this particular patient, and you can see that there is a right to left shunt, that the patient is desaturated at 79%. There's a normal cardiac index. There's also a little bit of a left to right, but it's predominantly a right to left. And we also see a little bit of mild elevation in the filling pressures, and the PVR is normal. So should this patient need to go for a Glenn, the PVR was 1 point something. So clearly would be potentially that could be an option. The next thing, we did angiograms. So angiography, of course, doesn't show you an anatomy as beautifully as you guys can demonstrate on MRI and echocardiography. But you can appreciate that indeed in the one on the right-hand side, you can see that the anatomy of Epstein's anomaly, it can be seen. The clearly is like the notch of the true annulus here. It's like a little line where the true annulus would be. And then the displacement and a sail-like anterior leaflet. And you can also get a hint of what the right ventricular function is. Take a look at the pulmonary arteries and make sure there's no stenosis or hypoplasia or anything that may need to be addressed at the time of surgery. So that's the purpose of that. We do a root angiogram in these patients, often to look at the coronary arteries. Sometimes, like in this particular patient, because of the massive right-sided cardiomegaly, you can see that the right coronary artery is very much like stretched. And one wonders whether the stretching of the coronary could have any impact on that right side function, and whether there may be some functional coronary insufficiency that is involved in these patients. And it's always also good to know what it looked before, because you will see sometimes it can change a lot after surgery, and if there is concerns for coronary compromise after the plication, you want to have an idea what the baseline coronary arteries were like, and also for help for the surgeons. So that's what we do in these patients. Next, yes.
Excellent. Thank you very much, Dr. Kreutzer. So next, we will talk about preoperative electrophysiologic studies and about the indications for that before the cone operation. And Dr. Gaurav Arora from the panel will comment on that.
Thank you, Tarek. If you could go next slide, please. So our protocol in Pittsburgh is for pre-cone EP study for patients either with known WPW, either currently or prior history of WPW that has not been treated or eliminated, known paroxysmal SVT, again, currently or previously not treated, not documented SVT, but symptoms suggestive of paroxysmal SVT. For patients with unexplained syncope, an EP study is indicated for both supraventricular and ventricular arrhythmias, or if they've had a prior EP study and we have concerns after reading that EP study that there could be residual lesions that might need to be dealt with. If there's a clinical arrhythmia that was atrial tachycardia or atrial flutter, we don't automatically do an EP study because we anticipate that the atrial reduction will improve hemodynamics, and cavo-tricuspid isthmus ablation, which we do routinely, we think would impact flutter. During that EP study, we would consider ablation of accessory pathways depending on patient size and accessory pathway location. As an electrophysiologist, when we go into the lab, we typically go in with a mindset of eliminating all accessory pathways. But one thing here with our approach for cone surgery in younger and smaller patients, we've had an approach now where if patients are larger or if the accessory pathways are close to the AV node, where we would utilize cryoablation to reduce the risk of AV block, those are the patients we tend to be more aggressive on to try and eliminate accessory pathway conduction in the lab. But knowing that they're going to the operating room in this coming days and that the surgeons have the ability to complete the ablation lines in very young and small patients, we're less likely to be aggressive with transcatheter ablation because of the risk to adjacent structures like coronary arteries. And if we can localize those structures instead, then surgical ablation can be performed in the operating room. And then we would do postoperative wire studies to ensure elimination of accessory pathway conduction. For ventricular stimulation, the next slide, please. We don't routinely do ventricular stimulation in all patients. The patients we would consider this are either patients with known ventricular tachycardia, patients with suspected ventricular tachycardia, or patients with a history of unexplained syncope. And then lastly, intraoperatively, our EP approach in Pittsburgh is that if there were accessory pathways identified that were not eliminated during the EP study, then those ablation lines are completed at the time of surgery. And then in addition, we do cavo-tricuspid isthmus ablation routinely in patients. And the idea is that the cavo-tricuspid isthmus participates in typical counterclockwise atrial flutter, and that part of that tissue could be covered at the time of cone operation and inaccessible via catheter afterwards. So our surgical team does a CTI at the time of cone for all patients. Yep.
Yeah, I would say that in these patients that go for invasive EP study, we typically also do a hemodynamic study at the same time since we have access, and that's so we do them combined.
Excellent.
And so I think for our preoperative team, we sort of make each of those decisions of, does the patient need a catheterization? Do they need an EP study? And then patients could have a combination.
Wonderful. Thank you very much for this nice summary. So to summarize, this kid has severe Epstein's anomaly of the tricuspid valve with double orifice tricuspid valve. So the tricuspid valve looks pretty complex. There was also mild to moderate degree of systolic biventricular dysfunction and significant cyanosis. And now I'm going to go to Dr. Da Silva and ask, like, would she be a good candidate for the cone operation given the complexity of her tricuspid valve and the ventricular dysfunction?
Yes, this anatomy is a little bit more complex than usual, but we usually can do the cone procedure in all kinds of anatomy presentation. And in this case, we were able to do the cone procedure.
That is great. So that is a nice segue to talk about what happened intraoperatively. So she underwent the cone operation with partial closure of the ASD and cavo-tricuspid valve isthmus ablation, as Dr. Aurora mentioned. And here's a nice video of the cone operation, and I'm going to ask Dr. De Silva to comment on that.
So thank you, Tarek. So during the operative procedure, we found everything that the echocardiogram showed to us, and even the long coronary artery, the super dominant right coronary artery. So we took care dissecting the anterior leaflet. We could see the two orifices, two bigger orifices, one rotated towards the RVOT, the other one smaller towards the apex. And here we can see the lamination of the leaflets here in the septal area. So we were able to detach everything. In this case, we need to do some procedures to avoid the bulging of the anterior wall of the right ventricle. So we need to do some plications, create some new trabeculations in the anterior wall. Here we are completing the dissection, trying to take everything in one point that would be the central apex of the cone. And here we need to close some of the orifice in the tricuspid valve. So here we are closing one orifice, and then we start attaching again the reconstructed tricuspid valve in the AV level. So we also decrease the size of the atrialized portion of the right ventricle with some plication. And here we are testing the valve, and the valve was competent at the end. We also did some annuloplasty in this case, and doing the annuloplasty in some enlarged valve like this, we need to be careful not to cause kinking of the coronary artery, especially in those right dominant coronary arteries. In this case, we were able to win from bypass, close the chest, but then the kid presented some arrhythmia at the end of the procedure, and we need to go on ECMO after that.
Excellent. Very good. Thank you very much, Dr. De Silva. So as you mentioned, these are the intraoperative findings from your note. So there was severely abnormal double orifice tricuspid valve. These features were consistent with type C Epstein's using the Carpentier classification. We'll look at that shortly. And also, as you mentioned, there was during the operation and before you close the chest, there was 2 episodes of narrow complex tachycardia, which responded to cardioversion at that time. And then when you did the cavo-tricuspid isthmus, it seems like they got much better. The atrium was very sensitive, the enlarged right atrium at that time. And then this is just looking quickly at the Carpentier classification of the tricuspid valve. This is a surgical classification, but we get close by imaging pre-op to try to kind of explain if, what type of valve that is. So in this case, it was a severe C case, like, between C and D. And what that means is that here you can see that the septal and posterior leaflet in this case was severely displaced. There was, in regards to the anterior leaflet, there was partial adhesion to the ventricular free wall and restricted motion. The atrialized ventricle was very large with reduced function, and the functional ventricle was relatively small, including only the RVOT with reduced function. Now, this is just looking at the post-op TEE quickly, looking at that tricuspid valve. You can see that there was only trivial tricuspid regurgitation, looking at the cone. And then you left a small atrial communication here, which was left to right in this case. And then when we looked at the function of the ventricles, you notice that the LV function was moderately depressed at least, and the RV function was moderately depressed at the end of this case. I'm going to go back to Dr. De Silva and ask, like, in such a case, when you see ventricular dysfunction after surgery, what will you be thinking about, and what will you, how would you approach that?
So if you had just right ventricular dysfunction, we could think to add some gland procedure in the patient. That was not the case. She presented biventricular dysfunction. So left ventricular dysfunction, in this case, could be explained for a combination of things like prolonged hypoxemia. She was on low sats in the pre-op. The distension of the coronary arteries, like Dr. Jack Kreuzer mentioned, we cannot say that that was the cause, but could be some kind of prolonged ischemia during her life. Also, the protection of the heart with cardioplegia could not be perfect, and also some kinking of the coronary arteries. So in this case, we placed the patient on ECMO and to support her. And then we opted to go to the cath lab to make sure that there was no kinking in the right coronary artery that could be a cause for the biventricular dysfunction.
All right, thanks, Dr. De Silva. So here, I'm going to show some of her angios, and I'm going to ask Dr. Kreuzer to comment on them.
So this first one is an aortogram, but the catheter is pretty much against the valve. So you do see pretty much a left ventriculogram. It shows you this marked ventricular dysfunction, left ventricular dysfunction, and you will appreciate all the coronary arteries filling. When we do these, we stop the ECMO flows, we clamp the ECMO for the angiogram so that we can opacify. Otherwise, it gets diluted and you don't get a good picture. The best views are the next ones, when you see in the lateral projection, where we can appreciate it in a selective coronary angiography on the right side of the screen. After surgery, you can see the difference between the right coronary before and after the extensive plication, how stretched it was. And now it's different, totally different course because everything has been plicated, but there's actually no obstruction. It's just somewhat tortuous, but there is good flow. So we were very confident that there was not necessarily a acute coronary issue that needed to be addressed. But you can appreciate how important it is to have very, very good surgical technique if you're doing these plications, and how it would be relatively easy to end up with a coronary problem without that surgical technique.
Exactly. And we are very happy here at Pittsburgh. We have an excellent ECMO support. And I would like to ask Grace to comment about the ECMO support that we can give to our patients. Grace is visiting here. Here we have Dr. Melita Viegas, that's the chief of our ECMO program. She's not here today, but she's also very helpful.
Thank you, Luciana, and thank you very much for having me. So when a patient comes from the OR on ECMO to us on the CICU, the first question is that why this patient is on ECMO. So we need to, what they did was perfect. They send this patient straight to the cath lab because we're doubt about the coronary circulation, and you always need to think about it. Because when you're on ECMO, you have two things. You need to have a perfect ECMO run, and you have to proportionate to this patient a perfect recovery. So if you don't know why this patient is on ECMO, you cannot treat whatever happened. So you're not going to have a perfect recovery, even if your ECMO run is perfect. So this is something that is very important. So when these patients, they come from the OR to us on the CICU on ECMO, so we have to solve this issue first, understand why he's on ECMO, but at the same time, we want to have a perfect ECMO with a perfect recovery. I always think that we should go system by system to be sure that we're giving everything that these patients need. And each phase of the post-op are different. So we have some things that are concerned on the first day of ECMO, right after the surgery, and other things that we're going to think a little bit more on the long run. So first of all, you need to know how your surgeon did your cannulation. And if he closed the chest or closed the skin, this is going to be something that's going to help your patient on the comfort and on the infection. But if you're thinking that you're going to have a long run, you can even tunnelize the cannulas or go to a peripheral. But usually on these cases, you're expecting to have a short run. So only closing the skin usually is enough. One thing you need to tell your team that when we change the practice, before you used to have open chest, totally open, but when you could see the bulge of the dressing if you have any bleeding. Now, if you close the skin, you cannot see anymore, so you have to be very alert about tamponade physiology. So this is about the skin of the patient, so and the cannulation. And then you think about the ECMO run itself. You need to think about how you're going to support your patient on VA ECMO. And this you want to this lactate to clear as soon as possible. You want to have a good venous saturation, good near. So these monitorizations are important, and you need to have a good blood pressure. Sometimes you need to work with the flow, with the fluid as well, because usually they're a little bit inflamed after the surgery, so they need a little bit of fluid replacement, but you don't want to fluid overload your patient. Another concern, especially when the patients are biventricular and with a small ASD only, is about the distension of the LV. So as we are thinking about giving our patient the best way to recover, we need to think about LV distension and how we can help our patient with this. So we don't want this LV to be distended because you can have clots in the LV. You can have a high transmural pressure. This is going to impair your coronary circulation, and this is going to impair recovery. You can have pulmonary edema and so on. So you really need to think. First of all, we try to treat this clinically, sometimes adding a little bit of milrinone. Sometimes if you need to have some ejection, a low dose epi can help, and you have to work with ECMO flow because the ECMO imposes a high afterload. So sometimes you need to decrease a little bit the flow. So you need to treat this on your post-op because you need your LV to be unloaded. If you're not able to do that, then you can go to more invasive procedures. And we usually keep these patients not on resting ventilation because they are not ARDS patients, and we want to wean as soon as possible. So, and we want the coronary circulation to receive some oxygenated blood, so we don't go too low on the vent settings the way we do on VV ECMO. And so that's usually what we do on the cardiovascular. And bleeding is another problem on the fresh post-op. You have to balance to have anticoagulation for your ECMO circuit, but at the same time not have a big bleeding. And then you have to deal with that on your platelets. Sometimes you can stop the heparin for a few hours until your patient, you can control the bleeding. So this is something you have to think about as well. We want these patients not, as I said, not to be fluid overloaded, but sometimes they need a little bit of preload for the ECMO to work well. So then you have to balance when you're going to start your diuresis. Sometimes you add CRRT for these patients as well. I think that's the basics that we do on the fresh post-op on ECMO.
Thank you so much, Dr. Van Leeuwen. That was wonderful. Now, luckily, the course of the ECMO was very short. So about 12 hours later, the kid was taken off ECMO successfully. This is the preoperative chest X-ray for comparison. And this is on post-op day 2. And you can see that the heart remodels very nicely acutely here. You see that the heart is much smaller compared to pre-op. And then this is the pre-op echocardiogram. So you can see the LV was dysfunctional. You can see how displaced that valve is. And you can see on post-op day 3, the LV recovered completely with normal function. The RV function was also low normal. And you see the post-surgical changes on the tricuspid valve. Now, when we look with color, you can see that before surgery, there was torrential tricuspid regurgitation with severe atrial enlargement. And post-surgery, it looks, great, pretty much. So there was only trivial tricuspid regurgitation, and there was no tricuspid stenosis. And one picture in short axis here, again, showing that the LV pre-op was dysfunctional with mild to moderate dysfunction, and that the LV function after surgery was back to normal. And then you can see a very nice on-fast view of that cone. So if you cut it, in a cross section, it looks more like a circle, and that's how you see it here in short axis. She did very well after she was taken off ECMO, and she was actually discharged home on post-operative day 10. And her discharge echo showed, as you saw the pictures, normal LV function, dilated RV with normal function, and trivial tricuspid regurgitation with no stenosis. This is 2.5 years later from last week. She's now 7. She seems to be doing great, very active. Mom commented that you can't tell that she even had any surgical repair. So some take-home messages from this case, and I'm going to then turn to the panelists and ask them what their take-home messages are from this case. But for me, as a cardiologist, it tells me that the cone operation can be performed successfully, even in this subset of patients with severe Epstein's anomaly, with pre-existing biventricular dysfunction and double orifice tricuspid valve. And also that extensive right heart glycation may cause coronary distortion or kinking, which can be avoided with the proper surgical technique and expertise. So I'm going to go now to the panelists and ask if you have any last comments on this case or anything special about this case that you learned from.
I would like to comment about the right dominant coronary artery. And in this case, Dr. Kreutzer showed with the heart catheterization after the cone procedure that we had distortion in some points, but no kinking, no obstruction of the coronary artery. So the surgeon needs to be aware of the size of the annulus, where to do the plication. Like I said before, sometimes we need to do the plication in multiple points to avoid the obstruction of the coronary artery. And to have ECMO support team is very important in those very critical cases.
Just to finish to comment on the ECMO perspective, this is beautiful to see how the team worked, because it was not a severe LV dysfunction. So maybe some centers would think about sending this patient to the ICU without ECMO support. For sure, we would have end organ suffering. And on this case, ECMO was done very safely, in a good way. And the team was not scared of coming off ECMO as well. Because sometimes you put these patients on ECMO and you know, let's wait 48 hours, let's wait more. No, they removed in 12 hours. So it was exactly what the patient needed. It was very well done.
Thank you.
I think it just, illustrates how important a good team is for getting a good outcome. You need, of course, the surgical expertise, but, excellent imaging is essential. And then you need to have the cath lab support. And you could see how different role it could be for cath in the prior patient. Cath played a role, at the level of the staging and the Glenn and coiling collaterals and setting up the patient so it would be a good candidate for the next step. This patient didn't need any of that, but had a different role. And then, of course, you need the EP expertise as well, because, if you don't take good care of the arrhythmias, this patient may not have been able to even survive the operation. So I don't know if you want to comment on that, Gaurav.
No, I think the biggest, in this case in particular, the patient didn't have any red flags preoperatively that made us do an EP study. But in this case, it sounds like the intraoperative sensitivity, my suspicion is that was atrial flutter that was happening repeatedly as the atrium was manipulated. And so I think tricuspid ablation, which is part of our routine approach here in Pittsburgh, I think is very helpful for these patients to decrease likelihood after surgery.
Right, that is wonderful. We have a few questions that came through the chat. So I'm going to start by a question about the use of 3D echo in such patients to Dr. Christopher and Dr. Da Silva for your thoughts on that.
Yeah, no, I think 3D echo has tremendous potential for this diagnosis and this procedure. We've been using it more often, I'd say, certainly on transesophageal echo in the operating room. But also it has tremendous potential for the more cooperative children to use transthoracic 3D echo, because it really, as we've seen, is a broad spectrum complexity for these valves, and so to be able to see both the valve anatomy with reference to the right heart is very important.
Yes, and I would like you to comment also regarding the use of magnet MRI, CT, or 3D echo. What's what you can see different in each test?
Yeah, no, each, I think we've talked in prior Epstein symposiums more kind of got into the details of, the risks and benefits of each modality, but they all, provide, I think, potentially very important but different information. The echo, certainly with better temporal resolution to really, capture the motion of the valve is really key. But of course, our windows are not always perfect. And I think we'll see in the last case a bit more use of MRI, where we're able to really critically assess the RV size and function, as well as flow patterns, right, which become key here to more accurately assess, the degree of tricuspid regurgitation, the pulmonary flow patterns, and then CT, of course, I think is being used more and more in our cardiology world these days. Certainly, as radiation doses come down, and we're able to do more dynamic gated CT to evaluate both, again, valve structure and Dr. Al-Said's got this perfectly queued up an example of a CT where we can actually visualize the cone itself in a postoperative patient. Yeah, so I'll stop there.
No, that was a wonderful explanation. And the ice cream is the right atrium pretty much. So excellent. Another question came and was about doing the cone operation in older patients. Like, would you have done a cone operation if this patient was, they mentioned 50 or 60? So any comments on that, Dr. Da Silva?
So we are doing adult patients here at the Children's Hospital of Pittsburgh. Even being at Children's Hospital, we received patients, older patients. So the oldest one was, I think, 50 something. Jose, can you help me? 49 years old. But we have one on evaluation that we probably will do next month. She's 60 years old. So, but to do this kind of complex anatomy, we would like to have like a full evaluation of the adult to see if there are any other comorbidities, because of course will be a prolonged surgery. And if a patient is too sick, if it's too old, then probably tricuspid valve replacement could be an option. In our experience during all those years, now with more than 350 patients operated in Brazil, here in Pittsburgh, in other countries, we replaced the valve only in 2 patients. So the cone procedure is applicable in many situations at all ages. So for that patient that's 60 years old, we are planning to do the cone procedure, to offer the cone procedure.
That's wonderful. Another question to Dr. Da Silva was about the preferred cardioplegic solution that you would use, and if it's different between children and adults.
We use the Del Nido cardioplegia, and this cardioplegia was developed here at the Children's Hospital of Pittsburgh. One of our perfusionists with Dr. Del Nido, when he was working here a long time ago, they created that kind of solution. And with that solution, we can stop the heart for like 1 hour. And this is very, very helpful for cone procedures, because when we were using the other type of cardioplegia, the St. Thomas, we would need to reinfuse the cardioplegia every 20 minutes. And that was the kind of cardioplegia we used at the beginning of our cone experience. So with this new cardioplegia, Don Cook was the perfusionist that developed that kind of cardioplegia with Dr. Leonido. So we can stop the heart, and 6 minutes later, we repeat a shot of that cardioplegia, and we have more 6 minutes. So it's really makes a lot of difference in the management of Epstein's anomaly.
That is wonderful. A question came to Dr. Van Leeuwen about what ACT would you try to maintain in patients on ECMO, and what kind of monitoring for anticoagulation do you have?
It depends of which anticoagulation you're using. You can do heparin or can do bivalirudin. And so we are trying to use more bivalve. The research is saying that it's a little bit safer. And so we are trying to change our practice to start with bivalve. Nowadays, we start with heparin and change to bivalve on the second day. ACT, as it monitors a lot of things, not only the heparin or the bivalve action, is only for you to have an idea. So what I usually do, people say, okay, let's keep around 180, but it doesn't mean for that specific patient, 180 is going to be your anti-10A or your APPT that you're aiming for. So what I usually do, we do the ACT, and we see with that range of ACT, what is my anti-10A or what is my APTT. So when I reach the APTT, if it's I'm using bivalve, or anti-10A if I'm using heparin, that I want, I'm going to see this is the ACT that reflects that. So if it comes out of that range, it's time for me to repeat this anticoagulation profile earlier than my usual Q6 hours. So I use the ACT only for a hint that something is not perfect, but not to change my anticoagulation.
That's wonderful. Thank you very much. A question came to Dr. Arora about, are there any cases where you would recommend more than just the CTI ablation? I think you touched on that a little bit during the cone operation.
I think the thing that comes to mind is if you have an older patient who has had atrial fibrillation and has an ASD, then you can think about doing a left atrial maze at the time. You know, right atrial tachycardias or right atrial flutters we often think about them going hand in hand with abnormal hemodynamics. And the hope would be that right atrial tachycardias or flutters with improved hemodynamics postoperatively might be better. And the other thing is that in the right atrial side, the cone operation itself is not going to prevent you from getting to right atrial structures other than the CTI. And so I can't think of a patient off the top of my head in the recent years that we've done a right atrial maze more extensively than a CTI. And you can correct me if I've forgotten somebody, because the idea is you're going to wait and see the effect of the hemodynamics. You're going to wait and see postoperatively how much atrial arrhythmia burden you have. And then if it is persistent, you can always take them back to the lab months later to complete anything on the right side. But I would say CTI has been our mainstay. And then in a few adult patients with paroxysmal atrial fibrillation, we've discussed whether left atrial maze at the time of surgery is worthwhile.
Mm-hmm. Wonderful. And then if you identify like an accessory pathway that can be dealt with during surgery, you would, in a child, you probably would suggest that as well.
Yeah, I would say that the experience that the Dr. De Silvas have given me in the last couple of years of doing EP studies on very young children, which is not routinely what we do. So what if we were doing EP studies on infants or young toddlers, then for me nowadays, I'm thinking much more about localization so they can complete surgical ablation. Whereas if we're doing a cone on a 10-year-old or 12-year-old or 14-year-old who has an EP substrate, then at the time of their preoperative EP study, I would approach that much more like I would approach a standard patient with normal heart and WPW, in that I was hoping to eliminate their accessory pathway conduction. I think it has to do with the size of the heart and the distance between the endocardial surface and the coronary arteries. And in very small children, you just don't have a lot of leeway. And you know, the other unusual thing about these patients compared to patients I take to the EP lab with normal hearts is that this patient's about to have their heart opened in the next 1 or 2 days. So as long as I can have an idea of where it is, I'm confident we'll be able to get rid of it. We do post-operative wire studies with the temporary pacing wires and use atrial pacing, ventricular pacing, adenosine to prove post-operatively that accessory pathway conduction has been eliminated. We actually just did that last week on a patient that had surgical ablation completed at the time of her cone.
And during the operation, after the ablation, if we see some area that was missing there, we can just ablate inside. It happened in the last case. We have a beautiful picture, and Gaurav always do a very nice job. But if there is any small area missing, we go there and do the ablation, because we do the cavo-tricuspideo ablation also, and then we can complete the anterior part.
Yeah, this most recent patient that she's talking about is a patient I took to the lab, had 2 accessory pathways. I eliminated one and could not eliminate the other completely, and she needed a cone. And Jose told me that you had one little spot between your ablation. You had ablation here, and there was one little spot in the middle, and we put the probe there after we were done, and she no longer has WPW.
It's a very integrated job. We work together for the patient.
That is really wonderful. Another question came about when to decide to come off ECMO. We have a few more minutes. So when would you decide to come off ECMO in these cases? I know, Dr. Van Leeuwen, you kind of touched on that sometimes you go on ECMO, but it's hard to decide when to come off. So how would you decide, Dr. Da Silva and Dr. Van Leeuwen?
So usually the ECMO in the post-operative period is a little bit different from the ECMO from a patient that arrested or had some kind of infection or things like that. Usually is kind of a combination of things, like I mentioned before, the cardioplegia, the surgical procedure itself. And like in this case, she recovered really quickly. And with the echocardiogram, with a better function, with the blood tests improving. So we are able to do the trial, the clamp trial, and we don't want to have the patient in the prolonged ECMO support. Usually in the post-op, we have a central cannulation. So as soon as we feel that the patient is ready, we do a test at the bedside. And this patient, 12 hours after we took her back to the OR, we did the clamp trial because the function of the heart had improved by the echocardiogram. So we were lucky to have the fast recovery.
Wonderful. Now we're going to switch gears for one last question about the teachability of the cone operation. How easy is it to teach the cone operation to a fellow or like another surgeon to do the cone operation, and whether 3D printing could be used to improve that?
So I correct me if I'm wrong, but I think the 3D printing for the leaflets of the tricuspid valve is still not possible to do. You cannot have a perfect model for the 3D model. That's correct.
It's challenging. We've printed at least one case where we combined the 3D echo image with the MR to give both the volume accurate representation of the walls structure as well as the valve, but very challenging, especially in the young babies that have been coming through more recently. Yeah, I agree. But the advent of newer materials to print with as well, that we've seen out of the Sick Kids group and others, certainly makes it more possible to consider training off of a model.
Yeah, so hopefully in the future we can print, and we need to remember that Epstein's anomaly, like Dr. Silverman mentioned before, we cannot just classify type A, B, C, D. I usually call like the 50 shades of Epstein's anomaly, and you need to have a great experience with some kind of cone procedure. So if one surgeon wants to learn the cone, I would advise to come here to Pittsburgh to participate in some operations to see live, and then we can show some movies of the surgical procedures, because Jose and I, we have a collection of moves in many different types of Epstein's anomaly. And even us, sometimes we are surprised with a different find that we can meet in the patients every day, especially if the patients from Poland, they are very challenging patients. So the last patient that I did from Poland, he had had a large muscular VSD. That's very unusual to find in Epstein's anomaly. So every patient is different, but the best way to learn is to see the operation and, if possible, to see many movies of Epstein's anomaly.
I would like to thank all the participants and the panelists. I think we're running out of time, but thank you so much. This was a great discussion. We have a few more questions that I will touch base with you after this and answer them through the chat, but thank you so much.